Dr. Frischke's stuff. And so first off, all right, so for today, the fascia lecture. Go back to the PowerPoint. The version that's on your thing may not have what I highlighted in red. But it's recorded, it's Panoptoed, right?
Yeah.
Will you have that for the weekend?
Yeah.
So
Yeah.
everything I highlighted in red, go back and go look at. Okay?
I knew it.
Yeah, of course you do it.
I did one of it. I highlighted.
Yeah, I mean, come on, let's be smart. Okay, so I'm gonna start off with this. I'll end with what Dr. Warner did on the, what was it, oral edentulous lecture. All about the denture system. It's all about denture, trust me. Okay, this should be really easy, a lot of this stuff. So for Dr. Frischke's thing, it's making sure you know what the different nerves he talked about do. So you can make sure that you know for PSA, it innervates maxillary molars except for the mesiobuccal cusp of the first molar. Okay? And it does get some buccal soft tissue on the maxilla. I'll show you that diagram at the end that pictures everything, but this is always a big one that everybody always loves because the one cusp that doesn't get innervation from PSA. So you always got to make sure you know that. I've got this up for a reason. Oh, what potential things? So if the needle is overinserted, it can penetrate the pterygoid plexus of the veins or maxillary. So basically, if you do a PSA block, two potential complications that come out of doing a PSA block would be damage to either the pterygoid plexus of the veins or damage to the maxillary artery or its branches of some sort. Okay? MSA innervates what? This should say maxillary bicuspids and the first mesiobuccal cusp of the first molar. Okay? So make sure you know that if PSA is not getting it, what must be getting it? All right? It's going to innervate buccal gingiva relative to the teeth that it innervates. Okay? And then ASA is getting cuspids, incisors, and that now labial tissue around where it's at. Okay. Greater palatine, hard palate. So when you think hard palate, two different nerves get hard palate. You remember that nasopalatine innervates the most anterior portion of the hard palate. So basically that stuff anterior to the incisive papilla, if you will. So all the hard palatal tissue just posterior to, or lingual to, whatever you want to think of, where the maxillary incisors are located at. The rest of the hard palate would be done by greater palatine. That makes sense to everybody? Should be easy. Nothing to that whatsoever.
I have a question.
Yes.
So I think in the greater palatine nerve, he said that it was something cuspid anteriorly, but then in the nasal palatine, it's also called cuspid anteriorly. So
Yeah. I can you're going to think the most anterior, go ahead.
Sorry, yeah, it took me a while to figure that out too. So that's the anterior border is what he's trying to say.
what does it mean by anterior border?
Like that's as far anteriorly as that one goes.
Oh.
It's like you drew a line across,
Yeah.
almost like from lateral to lateral. All that tissue anterior to that line would be by nasal palatine. Everything the hard palate posterior to that line would be greater palatine. Does that make sense?
Okay, yes.
Okay. Thank you, Durston. All right. So one thing to always keep in mind. Okay. Yeah, I thought I read it wrong for a minute. You can block both the ASA and MSA by doing an infraorbital nerve block. So that block, so you know if you took the needle up through the vestibule, went straight up, innervated where the infraorbital foramen is, you anesthetize both ASA and MSA. Okay, an infraorbital nerve block, you must remember that it will anesthetize all the mandibular dentition on one side, all the way. Okay? It doesn't do some teeth, it's getting all of the teeth. Molars, premolars, canine incisors on one side. And it gets a little bit of the buccal tissue that's basically kind of really up to about, I don't like saying that, molars anteriorly, because long buccal gets, so I'll show you on the diagram. When you think buccal gingiva, buccal and labial gingiva, you're going to be thinking long buccal nerve, and inferior gets a little bit of it, particularly mental nerve, but long buccal. Inferior, all the mandibular teeth on one side. Okay, when you do an inferior nerve block, you're going to remember relative to the pterygomandibular raphe. So where the raphe is, you're going to be inserting your needle lateral to the raphe, not medial to the raphe. That's the pathway that your needle is going to take to do an appropriate nerve block going to where the inferior nerve is located at. All right, make sure, this is probably hard to see on the slide, but make sure the difference of what you anesthetize if you're doing a standard inferior nerve block versus Akinosi versus Gao-Gates. So it's a matter of, why would you do one versus another? Well, a standard inferior nerve block will always get done correctly. Inferior nerve, it might not get lingual. It typically will. I mean, if you do it correctly, it should get both those nerves. An Akinosi will always get both inferior and lingual. The advantage or the reason why you do a Gao-Gates is you would get inferior, lingual, and long buccal. So getting all three of those, you would get anesthetize both the tooth and the gingival tissues on both sides of the tooth. I mean, that's not that huge a thing. You always do an infiltration to get gingival tissues, but it's the advantage that would give you is getting all the gingival tissue, typically, and the tooth as well. But just know which block gets which nerves.
Dr. Spears?
Yes?
Can you say the three for Gao-Gates again?
Gao-Gates would be inferior, lingual, long buccal.
Okay.
You will not typically get long buccal by doing an Akinosi. Definitely won't get it doing just an IAN. Okay, so main thing that's part of you're make sure you understand lingual nerve gets lingual gingiva. Yes?
So, if you do standard, would you get both I8 and Mafinoki Malahai?
What you get? Yeah, the answer is you should, but you don't really care if you get nerve to mylohyoid. Yeah.
Okay,
Okay. If you're trying to work on a tooth, you don't care.
okay.
But the only thing, it's a good question to ask because remember, no, it's a good question because sometimes you can get accessory innervation from nerve to mylohyoid to teeth. So the question is, can you get nerve to mylohyoid? And sometimes you can, sometimes you don't. So usually you don't. Okay, so lingual nerve, long buccal, you're making sure it's getting buccal gingiva relative to the molar region. Anterior to that is pretty much inferior. All right, so one thing that's wrong on this slide, that I put it up just because I wanted to correct it. It's not for the test purposes, just for your purposes. Okay, the mental nerve does not innervate any teeth whatsoever. Okay, what I suspect he is thinking, or what's calling it is, where inferior splits, it's, bless you, mental nerve is what comes out the mental foramen, going sensory to the skin, the lip and all that. Inside the mandibular canal, it continues on as what most of us refer to as the incisive nerve. All right? So maybe he's calling it mental inside the mandibular canal as well. I don't know. But I don't want you thinking mental nerve innervates teeth. Yes, sir?
So I know he had it on another one too that was like this hardcore thing with all the teeth and it showed them. So should we know?
Mental nerve is, but where you're looking at, is it not showing gingival tissues? Is not the side that's gingiva? Let me show. Are you talking about this picture?
Yeah, and the other nerves up top are showing the same kind of
But look,
outline.
this side says gingiva, this side says teeth. So what's showing you is the mental nerve is doing gingival tissues on this side.
But he didn't have incisive on his side.
Pardon?
But he didn't have incisive nerve on.
No, you don't have, I mean, I don't even care if you know, all I'm trying to get you to know is mental nerve doesn't do teeth. All right? It's still, you can still call it the inferior nerve if you wanted to. Mental nerve does not go to teeth.
So for purpose of the test though, which way do we?
It isn't on the test, don't worry about it. Okay? I just want, that's why I said, I just want to, for your purposes, please don't walk out of this course thinking you're going to one of your other, the clinic and telling you, oh, they taught us that the mental nerve, no. It is not sensory to teeth. So this diagram is a great one because it's showing you on the left side, the gingiva. So even if you look, it's showing you on the lingual gingiva, nasal palatine, greater palatine, lingual nerve. On the buccal side, buccal labial, if you will, buccal, mental, PSA, MSA, ASA. And on the other side, it shows what innervates which teeth. The only thing this diagram doesn't have is that mesiobuccal cusp that this one shows you, because it's showing you right here that that's MSA. Yes, sir?
Cusp or root?
Cusp, root, whatever. I was,
Both of them?
pretty much.
Because I feel like I remember on one slide it said root and other things.
Okay, it's really kind of the same thing, although it can not. The only reason I tend to say cusp and not root is because sometimes the roots are different on this tooth, and you just don't really know if you got the root or not. So anyway, these things will show you that distribution pattern. These should not be questions that cause you any difficulty whatsoever. Honestly, they're straight off the stuff, straightforward, easy peasy. Okay? Okay, so now let's go back to kind of review. So the, oh, pardon? Oh, okay. So this is different, yeah. I'm sorry. So I thought you had a question. So this review stuff. So you said you had to know stuff from oral cavity, TMJ.
He took care
He took, yeah.
But TMJ also includes muscles of mastication, right? Okay. So oral cavity, TMJ, muscles of mastication. So we're always going to remember that that palatoglossal arch was the boundary between oral cavity and oral pharynx. Okay, let's see. So make sure you go back and look at the slide about tongue muscles and what they do. Okay, so genioglossus, both protrudes and retracts. Main thing, keeps tongue out of the airway. So it's got a nice little descriptor here. You know, look at this different stuff and make sure you know what these different muscles do. The same thing I would say is remembering about, Katie, are we okay? Okay, you're trying to find it?
Yes.
Okay, I know. I put them up in just kind of a really random pattern, but Hillary's going to make sure everybody gets the copy of this and you're going to be okay. Okay. Make sure you know the muscle function and make sure you know the innervation to the different muscles. So all the muscles of the tongue are innervated by, somebody tell me, hypoglossal nerve except for palatoglossals, which is innervated by vagus, 10. Very good. Okay. So we got that down. I think I had this up for the same reason. Functions of the muscles. Yeah, let me see if there's something else on this other side. No, I think it's all about functions of the muscles. Okay. So from this slide, oh, okay. All right. So similar to, well, I remember he had a question about getting to the submandibular duct and how you had to go through like mucosa on the floor of the oral cavity to get down to the submandibular duct. You know, what would you cut through, whatever. So it's sitting there, the submandibular duct forms the sublingual fold. So what's a fold? A mucosa covering something, in this case it's a duct. So you'd have to cut through the mucosa in the floor of the mouth to expose, you know, let's say somebody had y'all heard the term sialolith yet? Salivary stone. So if you want to get a salivary stone out of that duct, what would you do? You'd have to cut through the mucosa, covering it, open up the flap, get into the duct, you'd be able to get the stone out. You're a hero. All right? You're also going to remember this relationship of the lingual nerve to the submandibular duct. You know that it passes lateral So medial going inferior to the duct. Always gotta remember that one. Okay? And then, if I forget about mylohyoid, remind me again. So we talked about infrahyoid muscles, maybe this was my prompt. So, mylohyoid in particular, is it the next slide? Yeah, there we go. So mylohyoid is all about forming the floor of the mouth, but remember it can also raise the hyoid bone, raise the tongue during swallowing. So mylohyoid, floor of the mouth, raise the tongue. No. Oh, I know what I did. I think I took it from, oh, so the other thing I wanted to remind you about was, Katie, you right where you're looking at these slides? Are you looking at the slides on your thing?
No.
I've got you all over the place. There's a slide, I know,
I
I'm
can't
going,
find them.
I know, sorry. There's a slide of, I think before this, whatever, that talks about the suprahyoid muscles. So it shows about stylohyoid, posterior digastric, all that type of stuff, whatever. Go back and look at the function of the, so basically, bless you, allergic to reviews. What the slide gets to is the fact that the suprahyoid muscles can serve two functions. They can be involved with either elevation of the hyoid bone or depressing the mandible, opening up the mandible during, I think that's the one.
It's slide 12 for everyone to know.
But the concept, everybody knows the concept. Just listen to me for a minute. What do the suprahyoids do? They have two functions to them. They can either elevate the hyoid bone or depress the mandible, pull the mandible down during jaw opening. Okay? Mylohyoid, floor of the mouth, raise the tongue, that sort of thing. Okay. Oh, so this goes back to when, so most of this is still reviews like we did last time. You gotta know the compartments relative to the tongue. So it's a matter of what was between hyoglossus and mylohyoid and that kind of stuff. So look at this slide. Remember, so if I go to the next slide, I'll show you the picture. So you can make sure you remember that if this is hyoglossus, so between hyoglossus, myloglossus would be the submandibular duct, lingual nerve, hypoglossal nerve, lingual vein, I wouldn't worry about that. Deep between basically the hyoglossus and the tongue would be the lingual artery, so deep to hyoglossus. And then out here, superficial to where the mylohyoid is, you would have things like the nerve of mylohyoid, a few other things, but mainly know relative to the hyoglossus. These structures, this structure. So just like it was on here, know that stuff. This is the same thing. This is really to remind me about the innervation. All muscles of the tongue, 12 except for palatal 10. Oops. Let's get. Okay, so this must be getting us to TMJ or something else. Yeah, but did this slide come out of TMJ? You would think so. I don't know.
It's on TMJ right now.
You're 100% positive.
The second one.
Okay. Well, thank you so much. So there's a couple of key points out of here. So he mentions about the mandibular fossa. So you remember that the mandibular fossa is divided in half by the petrotympanic fissure, and that's where the chorda tympani comes out. But the fossa itself, who was it? The other Dr. Warner actually gave you the name of the thing, but don't worry about it. Because there's actually a structure that divides it into two openings. It's not just on the petrotympanic fissure, there's a second fissure as well. The tympanic canal. Okay, so you can make sure off of this about the TMJ ligament, or what's called the lateral ligament of the TMJ, that, what does it do? It helps strengthen the lateral wall of the joint capsule. It restrains the condyle from moving too far posteriorly. Helps the condyles from being displaced laterally. And you're also going to remember that what prevents the condyle from being displaced medially? Spinous sphenoid. So this slide about the TMJ ligament and then about medial displacement. Make sure you know this slide, about what's happening where. All right, so the articular disc itself is attached to the head of the condyle by the two collateral ligaments. There's a medial collateral and a lateral collateral ligament. So that's what it actually attaches on each side. This line also has the note about spine of the sphenoid, reimburses the medial wall of the mandibular fossa, and prevents dislocation medially, prevents the condyle from dislocating medially. So this is an important point. The ligament being attached up here, that's an important point. And because of that attachment, what tends to happen? Oh, let's see what the next slide is. So I skipped one, I'll come back to that slide. So when the collateral ligaments are stretched or torn, the condyle may slip, resulting in a clicking sound. So for your purposes, clicking is because of what? It's because you've damaged the collateral ligaments, and now the disc can slide or pop off, or in this case, squirt anteriorly and cause a clicking sound. Yes, very important. Squirt, just like a little watermelon seed. All right, going back to this previous slide, what innervates the temporomandibular joint, you're always going to put the auriculotemporal nerve. I can tell you that's a national board question. There are some other things like the masseteric nerve you'll sometimes see or whatever, but always and definitively the auriculotemporal nerve is what innervates the TMJ. Okay. Oh, I know I had this one up here. Okay, so remember there are two types of movements that occur, called either hinge or I always call it rotation. Rotation or translation. Hinge, which is rotation, sliding is translation. So remember, you have a disc in place, and the disc separates this into two joint compartments. So between the head of the condyle and the disc is the inferior joint space. Between the disc and the articular eminence between the temporal bone is the superior joint space. Everybody with me on that? Easy concept, right? All right. So rotation always occurs in the inferior joint space, joint compartment. Because what rotation is rotation of, so if my hand is the disc, rotation is always this, right? So if it's the condyle rotating, it's always got to be between these two structures. Translation is in the superior joint compartment, because it's always going to be between the disc and the temporal bone, because what happens is the disc is attached to the condyle, like that, so you know, rotation. And then when it translates, the disc and the condyle move together. That's translation. So the translatory movement is not between these two things, it's the disc and the temporal bone. Okay? Even if you don't understand it, just put it there. Translation in the inferior joint compartment between the disc and the condyle. Translation between the disc and the temporal bone. So if the disc dislocated itself anteriorly, or if you had adhesions between the disc and the condyle, which movement would you hinder? Between the disc and the condyle, what movement would you hinder?
Translation.
Rotation.
Rotation.
Rotation. Thank you. If you had adhesions between the disc and the temporal bone, what would you hinder? Translation. Okay? This is a long slide, but that is in here, it's important. I think I've got it up here because of the retrodiscal pad. Oh, I know. So, okay, the retrodiscal pad, you know, is the part that contains all the blood vessels, a lot of nerve fibers and whatever. Remember, it's located posterior to the condyle. And so the pad can be compressed by a posterior movement of the condyle, trapping the disc. Oh, that's okay. So if the pad is stretched or it's compressed, what can happen? Pain, inflammation, swelling, and that swelling might cause malocclusion. So what three things could be related to inflammation or something of the retrodiscal pad? or damage to the rectum or something, pain, inflammation, malocclusion. Okay? Great job. Y'all are doing wonderful. Did I just copy the same thing twice?
Dr. Spears,
Yes?
what's the difference between, or is there a difference between the capsular ligament and TMJ ligament?
If everybody, the question is, for those of you out in the audience, what's the difference between capsular ligament versus lateral ligament versus TMJ ligament? Basically all the same thing. Sometimes people use capsular ligament to be more than one thing. Like you could have a couple different capsular ligaments if it's associated with the capsule, but for most people's purposes, it's always referring to the TMJ or lateral ligament because it reinforces the capsule laterally. I think I already had the slides, so I went the wrong way with that. Okay. All right, so this is the latter part of the TMJ lecture, so it gets into muscles of mastication. So this one where you just got to go back and know your muscles of mastication. Origins, assertions, actions. Surely everybody knows innervation at this point in time. What innervates the muscles of mastication? Say V3 for me. I'm going to see y'all in the hallway. And I'll ask you that. I'll say, first, what are the muscles of mastication? Temporalis, masseter, lateral pterygoid, medial pterygoid. What innervates the muscles of mastication? V3. What innervates the muscle of facial expression? 7. There you go. I'll ask you. I promise you I'm going to. You know I'm going to ask you 2 things.
7.
One, got that one wrong. First thing I'll ask you is muscle mastication. What's the second thing I'll ask you? Are you making progress towards your DDS degree? Everybody making progress? Great. Life is really good. Okay, so make sure you know the muscles, their attachments, all that kind of stuff. If you do, you'll be good to go. If he's got any type of thing in there. Oh, so 4 muscles of mastication. 3 of them are involved with elevating the mandible. One's involved with opening, or jaw opening. Who's the one that's the exception? You got to be more specific. Lateral pterygoid, inferior head. Superior head really is not involved with opening. It's controlling position of the disc as you open and close. But nothing. Lateral pterygoid is the one that's involved with jaw opening. It produces translation. Okay. Talks about masseter. It may retrude the mandible, but for your purposes, what's the muscle of mastication most likely to retrude? Pull the mandible in a posterior direction. Temporalis. Okay? Because it's got these posterior fibers like this, it's the most likely one to retrude, pull it back. Masseter can do a little bit of that, but this is the one that really retrudes the mandible. And temporalis, most responsible for intercuspation. So if you write stuff on that, you know you gotta look at that. You gotta look. Just gotta do it. Again, know the attachment points. Medial pterygoid has a bunch of attachment points. Know them. Maxillary tuberosity, perimeral process of the palatine bone, medial part of the lateral pterygoid plate. There you go. Any questions about muscles of mastication? Y'all are in good shape. You remember all that stuff. Hope you remember V3. Okay, moving on. I think most of the other Dr. Warner stuff for this lecture should be straightforward. Most of it was review, so it should have been stuff that you pretty much knew. Okay, so you remember that really you're going to focus on autonomics. So something like, autonomic nervous system, whether it was sympathetic, parasympathetic, he taught to you that it's part of the peripheral nervous system. All right, so he showed you a pathway for a sympathetic axon. And so make sure you understand that you would find parts of the sympathetic axon in the intermediolateral cell column, ventral horn, ventral root, white ramus to a ganglion. So, remember, if you will, it's a secretomotor neuron going out to make something, smooth muscle, cardiac muscle, glands function. So it would not be involved, this part at least, with dorsal root ganglion, dorsal horn, because that's a sensory pathway. All right? So here is the pathway of that first neuron. And as you know from here, it can go multiple directions as he went through. All right, Horner syndrome. Classic, always remember, ptosis, meiosis, and hydrosis. Or if you'd like, ptosis, meiosis, and hydrosis. You can say the P or not if you want, I don't care. Yeah, ptosis. So who in here, I have some researchers, but didn't mean to do this. So there's a process of cell death. What's, you know the term for,
Apoptosis.
so what did you call it?
Apoptosis.
Yeah, I was there, apoptosis. It's apoptosis. Tosis, there's no pop. Everybody says it the wrong way. Everybody says it. That's because they taught you the wrong. I guarantee your faculty person will say apoptosis. No, it's ptosis. It's apoptosis. It's not apoptosis. It's apoptosis.
That sounds true.
Ptosis.
I've never heard
We
that.
don't pronounce the P. It's ptosis. Just like I know my Clint Apps group for the first time will remember this, whatever. It's not preventative, it's preventive. There's not a word called preventative. It's preventive. Right, Stephanie? Yeah, my first group, we talked about this. It's preventive. Preventative, not preventative dentistry. Preventive. It's become a word in the dictionary now because so many people don't know, but what would preventative be a derivative of? Preventative or something? I mean, yeah. Thank you. All right, so know what Horner syndrome does. So ptosis, drooping of the eyelid, meiosis, constriction of the pupil, anhidrosis, lack of sweating, decreased sweating. All right, so make sure you know what's associated with Horner's. Make sure you know about Hirschsprung's megacolon. Okay, so abscess, colon, it decreases colon motility. You end up with a dilated colon. So know about Hirschsprung's megacolon. I got another one coming up in just a minute. I'm trying to go kind of in a little bit of order. So he went through what the different nerves do or whatever. So you need to look through these slides and make sure you know what the nucleus is, what the ganglion is, and then what the postganglionic axons travel with. I know it seems superfluous or superfluous, whichever you like. Maybe I can teach you some more linguistics, but we won't do that today. Duodenum, duodenum, that's a good one. So, or is that Edinger or Edinger? Yeah. All depends on how you were trained. Preventative, all depends on how you were trained. So make sure you know those little points and the different ones. Oh, there's the other one. So, oh yes, sir.
What is the large pupils to small mean? Nope.
This slide or the next one?
That one.
Oh,
He said that like sometimes you have large people, sometimes it's small.
Yeah.
It's like not a definite thing, if I remember it correctly. Like the first one.
he's
is
right.
lateral and
Well,
the
she's
second
right.
one
What she's telling you is, he was saying that while it tends to be large pupils, it could be small pupils. So, while it could be, there was something else on a couple of these. So while while typically it's unilateral, it might be bilateral in 20% of the cases.
It's okay to have a question.
Yeah. So, of course, he made the big deal about learning Argyle, Robertson pupil. So make sure you know about Addies as well. Really make sure you know about Addies as well. Yes. Okay, for the petrosal nerves, I think everybody's got this down because we've done this multiple times. You know that greater petrosal is a preganglionic parasympathetic nerve. Lesser petrosal is a preganglionic parasympathetic nerve. Deep petrosal is a postganglionic sympathetic nerve. Okay? Greater petrosal comes from where? 7. Lesser petrosal, 9. Deep petrosal, sympathetic, so it's coming from the superior cervical ganglion, postganglionically. And Vidian or nerve, the pterygoid canal, is a mixture of, must be preganglionic parasympathetic, postganglionic sympathetic. Everybody's got that, right? Nerve to pterygoid, Vidian nerve. It contains preganglionic, parasympathetic, postganglionic, sympathetic. Neurotransmitter-wise, it's always, you guys can figure out what's the exception here? Postganglionic sympathetics, noradrenaline. Everybody else, acetylcholine. I mean, you guys could write, just ignore that for now. You guys could write national board question. That's a classic national board question, okay? It's always about the exceptions. So, look at this or whatever, this last part, remember, it's how I always, we told you, point and shoot. Erection is a parasympathetic, sympathetic ejaculation. But you don't tell me I gotta explain that one to you, because I'll be embarrassed about that. I'll have to explain it to you. You somebody else to explain that one to you. I'm sorry, maybe I should have taught it that way, but that's how I can remember peeing, that's how I remembered it. So, it's how we were classically taught it. So, after this is over with, somebody will explain that one to you. If nothing else, remember, erection is parasympathetic, ejaculation is sympathetic. That's what you need to learn. Okay. Is that really all? Oh, no, I gotta go back. Well, no, I'm just gonna tell you. I won't spend a lot of your time here. So on his part that he did the edentulous mouth lecture, it's about denture manufacturing. When you go through that, look at anything he related to about the denture, whether it was in the way, whether it prevented slippage, whatever he has in those slides about denture. You know how he is. Go through and look at the pictures. And anything you wrote on them, let me see if I can come up with some good ones here or whatever. Okay. Yeah, look at these things. These are all important points. Denture locks in the hamular notch. Tuberosity prevents anterior lateral movement. Okay, good to know. Something you probably better know. Pterygomandibular fag must not impinge on upper, denture. Labium buccal frenulum, if present, may impinge on denture, causing ulcer. You guys have taken enough of the test now. You know what to look for. Those are the points that are important. Okay, so when you go through, read these things, and that's what you need to know.
Sir, back like 3 slides. It has 3 parts of hamular notch. What were those? I don't think you ever mentioned
the hamular notch.
Oh, yeah.
Really, what it is just 3 parts. I think the hamular notch was part of it. So it was the pterygoid hamulus, the notch, and then the maxillary tuberosity. Those are basically the 3 parts of the hamular notch. The notch itself is part of the notch. Makes sense, right?
Well, he said
Pyramidal,
he said it was the pyramidal process.
Yeah.
So include, okay, there you go.
Tuberosity, that 3 things made up of the notch, not me.
Perfect. You should be down here giving the review. Oh yeah, you are. What else?
Can you go up to like 3 slides?
3 slides before or after?
After.
1, 2, 3.
Yes. So it said vibrating line is the boundary between the heart and the top, and then that sentence after that.
Okay. So what he's basically telling you is, all right, does everybody understand what the vibrating line is? So basically, you can get people to make sounds, do different things or whatever, and the palate will vibrate, and that's where you can tell the difference between soft palate and hard palate. So what you're wanting to do is you're wanting your denture that you're seeding to be about 3 to 4 millimeters anterior to where that vibrating line is. You don't want to be close to that line because then it tends to not seal and do as well. So what he's trying to get across here is that in this area, if you come 3 to 4 millimeters anterior to it, there's a lot of glandular tissue that's present there. There's some fatty tissue that's there as well. And so it forms a better seal there than if you're actually on the vibrating line or posterior to the vibrating line. So if you can look and see, visualize where the vibrating line is, anterior to it a little bit, is the perfect place for your denture to end. You're welcome.